This is a very interesting drug. It's a drug antibody or a conjugate that targets CD22, which is present on ALL cells, typically B cell ALL. And in the Innovate study, which we discussed tonight, in patients who had refractory disease, so truly refractory ALL, this was not MRD like the BLAST study, but in patients who had significant relapse disease or progressive disease despite their chemotherapy that they received, this drug was actually effective at attaining remissions. Now, those remissions are typically short-lived. So they're effective, it's a very effective drug, but it should also be considered as a bridge, once again, to allogeneic stem cell transplant. As I mentioned before, patients who have refractory disease, they should go to transplant, whether you get them into a remission with standard chemotherapy or, per the Innovate study, Inotuzumab. But I believe this drug could be a very effective agent to bridge patients to transplant. But one word of caution with Inotuzumab is that it is associated with veno-occlusive disease. This is also associated with stem cell transplantation. So in patients who are receiving Inotuzumab prior to a stem cell transplant, there has to be a lot of discussion and consideration, as giving chemotherapy with transplant can also induce the same veno-occlusive disease. So I would strongly consider avoiding chemotherapy agents that are known to cause veno-occlusive disease in association with the stem cell transplant, such as busulfan, when you use this drug. But for this reason, I do think that blinatumomab, which also is approved in this relapse refractory setting, we didn't discuss it as much today, that drug at Ohio State we use often in this situation because you avoid the potential complication of veno-occlusive disease and making it worse with the stem cell transplant. But certainly both agents are NCCN recommended as bridges to an allogeneic transplant.